How powerful is this computer? Because how much memory is on this computer? Because it's my video doesn't appear to be.
It's never
had a problem.
I think a lot. I don't think it's ever been a problem. What's happening?
All right. It's just that I can't play the video, the embedded video.
Yeah. That's a resident issue. It's going to the resident video, the resident player. So it won't necessarily play a video. What you might want to do is play the video. Can you play the video outside of the PowerPoint? Because this is going to a resident player.
Right.
If that, we often have that where the video is different. It's playing. You'll only play on a different.
Right.
Because I can go. If we can get the video, we can put it onto the desktop, and I can go open with and pick another program.
I see.
But because if it's embedded in, it won't play because it goes straight to the resident.
I see. Okay.
Yeah.
Well, let me just see here.
Yeah. So you can do that.
I don't think so.
Or you're just wondering if you can play this off the laptop.
Yeah, we can play it off the laptop.
Yeah, laptop. You have a laptop? You want to do that?
I have a laptop. Yeah.
Do you have a dongle?
Dongle.
Yeah, the connector. If not, I have one in my bag.
If you don't, I also probably have. That would be good, because then if it plays off your laptop...
It'll play on your laptop.
Okay. I need a power source. So does this
Yeah, I'll look at it over here. Great, thanks.
Yikes. Okay. I don't know, I'm just using my laptop, see if it's okay.
It's just that with the PowerPoint, with it embedded into the video embedded into the PowerPoint presentation, this is looking for its resident player, and if it often won't play it if it's not the right player. So it can be played as long as it would have to be outside the PowerPoint as a separate video. And that's just because the computer only has one resident player. It can't do two at the same level. So it goes straight to the one that won't. I think this is media player.
Okay, so now my computer to attach to the screen.
So we're
okay.
going to switch here to this one. And you are... Okay, so yeah, just get it working there, and then I will plug you into the projector.
Okay.
Good. So you should hear the video here on this on its speaker, because we're not plugged into the house speaker yet, so we won't hear it yet in large volume.
Yeah, I don't think that there's any sound on any of the videos.
Okay.
Yeah.
No worries then. We won't worry about the sound. So, and do you have your adapter?
Adapter.
Yeah, to plug for this to go to here. Yeah. Otherwise I can get one for you. Yep. Okay.
All right. Yeah. I know. Seriously.
There's always something.
Do you have your? You're gonna wear this?
Yeah.
That's me.
Not the same one. Far away.
Oh,
Thunderbolt? Yeah, Thunderbolt. Nobody can open.
So yeah, so is it a mini? What's the plug?
It's a Thunderbolt.
Which is yeah. Oh,
You can play it on my computer.
that one will work too.
Yeah,
The little mini. Yeah.
Do you have one?
Yeah. I'll go get it.
Thank you.
I forgot you had an older computer. Not up to date.
What do you say?
It's probably PCs. They always have some good pressure. You're gonna play it on the max side, right?
Yeah. So let's see if it should. Yes, it does.
Okay. Okay. I have a
I'll put my time.
toilet.
There you go.
We need a.
And then once you put that in, just take this one.
Okay.
So far, no.
Yeah. Give it a sec here. Sometimes it will take long.
Eric, you did a great job. Now we're all black.
Okay. Try lowering the resolution on this, because it might be too high a resolution. Yeah, just try that, because it looks like it's struggling to go up there, but it's not. You just hear display. Yeah, go into displays, and let's see here. How much? Mirroring, yeah, you got that. Set. And just go with that and see if that makes any difference. Well, it shouldn't. It'll take a few seconds. Let's give it every switch. There you go. Okay. Okay. Excellent. And you don't have sound, so we won't plug in this. Okay.
You're an amazing guy. Yeah, you're right.
Trouble is sometimes it takes a while, right?
You're an amazing guy. Okay. Oh, just use the mouse.
I can put down.
Good morning, everybody. I'm sorry we're a bit late in starting. Technology, again, trumps the day. I also want to remind you that for those of you that are using the forms for assessment of the grand rounds, you'll see that the form is incorrect. And this is not Dr. Beverly Jung, and this is not a renal round. This is about gastroenterology. So please make the corrections. Today's speakers, Drs. Whittaker and Lamb, will be speaking to us about, I'm not sure what they're speaking about.
Hopefully we are.
Hopefully they are.
Thanks, Dr. Casson. So I'm going to speak at the beginning and the end, and the most exciting part will be Dr. Lamb in the middle. So we're going to talk about diets, drugs, and dissections. We're going to start with drugs. I'm going to talk about a very specific drug. And this is going to be a drug on the treatment of short bowel syndrome. And we want to be able to define short bowel syndrome and understand our treatment options. And the question is, how short is too short? And Dr. Coe originally had a slide with women with short skirts and men in short pants, but I elected to not do that in light of today's modern world. So the definition of short bowel syndrome is it can be a functional definition, but that's not generally used. It's usually used as a small bowel length. So anything less than about 2 meters, 200 centimeters is considered short. What's interesting is we were taught in medical school, I think, that the small bowel was 6 to 8 meters long, but it turns out that in cadavers it's more like 3 to 3.5 to about 8 meters. So some of them are quite short to start with. And so if you're born with, or you develop as an adult a fairly short bowel, then 200 centimeters may be a fair amount of the regular amount of small bowel, whereas if you had 8 meters, obviously you'd have to take a lot more bowel out. And the prevalence is not, and this is going to be an important thing at the end of the discussion about it. So in 1992, it was a 1995 publication, that worked out that there were 40,000 patients in the U.S. on TPN, and it worked out that 10% of them had short bowel. In any event, the estimated prevalence of short bowel syndrome in the U.S. is 1 in 10,000, but more recent estimates are 1 in 100,000. And the variance, do I have a pointer here somewhere, or do I just use where's your mouse? I can't seem to use it. Okay, that's fine. So the prevalence has varied quite a bit across, even in Europe, so that in Poland it was 0.4 for a million. And in Denmark, where one of the gurus of short bowel syndrome, a guy named Jeppesen, Pelle Jeppesen, resides, it's 30 per million. And so that range is a wide range of various prevalences, and it probably relates to local expertise and local knowledge. And in BC, we estimate it's probably 1 in 100,000. So it's a relatively rare condition, but an important one in terms of cost, as we'll see. The causations are shown there: Crohn's disease, vascular problems, small bowel volvulus, radiation. So majority of our patients who have short bowel, probably the majority are Crohn's disease followed by ischemic problems. And we have the rare, almost a total small bowel volvulus where they've had to resect most of the small bowel. So why discuss this? It's rare, but the treatment's expensive. And it's been estimated that TPN, if you're going to use parenteral nutrition in these patients, it runs somewhere in direct costs, doesn't include indirect costs, somewhere between $100,000 and in the U.S. up to $500,000 U.S. per year to treat these patients. That there are some new medications available, and I want to talk about one of them, the one that's actually approved. And this leads to two issues: the concept of orphan drugs and the ethical dilemmas in the cost of these drugs. So there was a recent estimate that the worldwide cost for short bowel syndrome is going to be around 2.7 billion US, which is about 30 trillion Canadian. When you look at the estimate, if you look at just the population of the Earth and divide that by what we have in British Columbia, it suggests it's around $2 million. But you have to realize that many parts of the world, Africa and large parts of Asia, have very little support for short bowel syndrome treatment. So that's a gross underestimate for what we would spend in Western cultures, Western societies. But 2 million Canadian, and that's probably an underestimate what it would cost for us. Now, where the short bowel problem is really important. So you can see that we have a duodenum, roughly half of the small bowel is jejunum, the bottom half is ileum. It turns out that you can get away with with resecting a large amount of jejunum, but you can't get away with resecting a large amount of ileum for a couple of reasons. One is that the tight junctions in the tremalium allow much better salt and water absorption, and even better in the colon. And in addition, if you have no ileum, you can't really compensate for the jejunum. If you take very high osmolality solutions, it brings a whole bunch of fluid, and you can't really reabsorb it very well. So we can get away with a fairly decent-sized jejunal resection, but not much ileal resection, which is unfortunate because if you look at ischemic disease, we usually lose the ileum, and usually what we're left with is jejunum. And similarly with Crohn's disease, we usually have the ileum resection first, and we're left with a lot of jejunum often. The shortest bowel we have in British Columbia is a woman who has 6 centimeters of jejunum. And that's all of the bowel. She has no colon, no ileum, and only 6 centimeters of jejunum. And the colon's important, as we're going to see in a second. The colon's really important because we don't think of the colon as being an absorptive organ, but it turns out that when you deal with complex carbohydrates, you form short-chain fatty acids, and those are well absorbed in the colon. And if you have a colon in continuity, it's roughly equivalent to about 40 or 50 centimeters of small bowel. That's important because when you're dealing with bits of small bowel that are short, if you can hook them up to a functional colon, you can gain an extra 40 centimeters. And the magic number is usually around a meter of small bowel. We can usually get away without TPN. The meter of small bowel can be 60 centimeters of small bowel plus a full colon, which is another 40 centimeters, or it can be 100 centimeters of jejunum to an end jejunostomy. So that's important, and then therefore it's really an asset. It's particularly an asset when it comes to fluid and electrolytes because the colon's so good at reabsorbing. So what are the factors allowing us to absorb? Well, obviously, the length of remaining small bowel, the type of small bowel remaining, I've already talked about jejunum versus ileum, the presence of the colon, and intestinal adaptation. And you can tell from the first three that mostly there's not much we can do about the fact. I mean, you've lost your ileum, you've lost your ileum. We have no way to manufacture that. If you don't have a colon or can't access the colon in continuity, you can't do much about that. But we may have a way to deal with the intestinal adaptation. And this occurs through two major mechanisms. One is a structural thing where the bowel gets hyperplastic, it gets dilated and elongated. So it's a way of giving you more small bowel absorptive mucosa. And there's also some functional changes that we really don't have the time to talk about today. This general intestinal adaptation can take up to 2 years for maximal effect. And it, as mentioned, villus lengthening, small bowel dilatation, improved function. And we need to expose the small bowel mucosa to luminal nutrients. And most of that exposure leads to, in the distal bowel, from enterocytes, the release of GLP-2, which is Glucagon-Like Peptide 2, which is released in the ileum and colon through L cells, and it stimulates the jejunum. GLP-2 there, as you can see, it stimulates jejunum for the kind of functional and structural aspects we talked about. GLP-2 is a very short-acting peptide. It's 33 amino acids long. But if you make one amino acid change, you have a drug called Teduglutide, and that markedly lengthens the duration in the body. The half-life is markedly changed, and so you can give it once a day subcutaneously. And that drug, we had other drugs that were tried to improve intestinal function. They include human growth hormone that didn't work. And GLP-2 is the one that the analog seems to work. And they have done a number of studies. The first studies used 2 different doses, and we were involved in the first study, worldwide study that was done. And the second study used the smaller dose. And that's the one we're going to talk a little bit about today. This was published about 5-6 years ago by Jeppesen from Denmark. And there was a 24-week study, very complicated study. I'm not going to go into great detail on it, but it looked at whether we could decrease the amount of fluid given. It didn't specifically address nutritional material, but it looked at trying to reduce fluids in these patients. And so that's a complicated slide. It's in 2 parts. The first part is a stabilization period, because if you have patients coming into the home TPN clinic, they're often on several liters of fluid. And the idea of the first few weeks was to stabilize them, try to get the minimum fluid, so you had at least 1 liter of urine output. And then you'd put them on placebo, or you put them on the drug Teduglutide in a double-blind randomized study. And once they're stabilized, they went into 2 arms, either Teduglutide arm, which is weight-based, or placebo arm. There's 43 patients in each arm, and it was conducted over a period of 24 weeks, and every 4 weeks there'd be an adjustment in the amount of fluid, trying to keep, if there was an increase in the amount of fluid, you try to reduce it by as much as 30% of the fluid you needed, and they looked and see how much they could reduce the fluid to. And this is the results. The thing in black is Teduglutide, and on the y-axis you can see that this is the change in fluid status. So even the placebo group, which is the lighter gray one, in a period of 24 weeks, had a 2.3 liter reduction per week. That's only per week. And in the Teduglutide, it's 4.4. So you could say, well, that's only 2 liters per week. That's not much fluid reduction. As it turns out, and the study was only conducted for 24 weeks, this continues on for a year or 2, which is what you might expect because of adaptation changes that we already knew that can occur over 2 years. So the question was, this doesn't seem like a whole lot. Can we actually get freedom from intravenous fluids? And there was a post-hoc analysis of 5 clinical trials with 134 patients, and 16 of them, just over 10%, gained oral or enteral autonomy after a median of 5 years. Half of them were female. They were younger than I am. They had the mean baseline volume was only 5 liters per week, but it's interesting that some of them had really quite small amounts of small intestine, but most of those had a colon, which is a critical part of this. So there have been patients who can get IV autonomy, and we've had one patient in our BC program who had been on TPN for, I don't know if Andre knows how long it was, 10 or 15 years, and she's now off home TPN. So we actually have one of the patients, not reported in this study, but we have one patient who's come off parenteral nutrition. There are some issues with this drug. It's a stimulant to the bowel. It stimulates the large bowel as well as the small bowel. We do see problems with a lot of GI upsets, nausea, bloating, and the stoma can get quite large and sometimes unmanageable. Often we need changes in the stoma. We need to get a stoma nurse involved because it actually gets very puffy in the stoma. There's concern about intestinal neoplasia, so people need to have a screening colonoscopy to make sure they don't have any polyps or cancers, and they should be screened on a regular basis. And some of these patients who've had things like radiation or 15 surgeries, doing a colonoscopy in these patients is amongst the hardest colonoscopies you can ever imagine doing. And of course, we also have to worry if they're on oral medications. that they've seen patients who have a marked increased absorption of these oral medications, and that can lead to some issues. So you have to follow those very closely. Cost. So remember I said the initial estimation in the U.S. was that there are 1 in 10,000 patients, 1 patient in 10,000 subjects in the U.S., and then we changed it to 1 in 100,000. So they originally thought they would have dealing with roughly 36,000 patients, and they were going to charge about $20,000 US per year. That was on the line with the other biologics that are available. But when they did the recalculation, they decided it was only a tenth of that. So what did they do? They changed the price of the drug from $20,000 per year to $200,000 per year, which translates in Canada to about $300,000 per year. This is given a single injection once a day, 0.05 milligrams per kilogram. So I leave this open. Can we afford this? It turns out that there is no coverage in British Columbia through the government, but we have had approval in private payers to pay $300,000 a year for some patients. And if you got the patient off TPN, the TPN probably costs $100,000 to $200,000 a year, so it's not so much. If it's a reduction of only 2 liters a week and they get off TPN for 1 week, that's a very expensive day of the week to be off TPN. So I'm going to pass it over, and we're going to have a second discussion, and Dr. Lamb is going to talk about the D part, the dissections part.
Okay, thanks, Scott.
We'll start taking questions at the end.
Okay, so my talk, diets. We're going to go diets afterwards, I guess. Oh, Scott. You want to talk about diets now, or no?
No, you're going to take.
All right, okay. All right. All right. So let me just switch to the... Okay. Okay, so my talk is about dissections. What's new in gastroenterology about endoscopy? So we know the role of endoscopy has changed. There's been some change. Okay, the role of endoscopy has changed how we practice medicine from the initial use of modern endoscopy in the 1960s with purely a diagnostic focus. It then went on to basic therapeutics such as hemostasis and biliary endoscopy. And then more recently with endoscopic ultrasound, we're expanding this focus, so to speak, of where we can affect change. And so what's new in endoscopy is exploring what's called the third space, and that is the area between the mucosa and the serosal surface within the bowel in a process called endoscopic submucosal dissection. And this has really been possible mainly due to improvements in our endoscopes and the devices that we can do to access this space. Now, why is this important? Well, we deal with a lot of superficial neoplastic lesions in the colon with polyps. And if a patient has, for example, a very superficial lesion involving the epithelium or very superficially in the submucosa, there really is not a need for surgery to gather lymph nodes and assess the lymph node status of whether cancer is there, because a lack of a lot of vascular and lymphatic supply. And so when we look at targets for endoscopic removal, we look for very superficial lesions such as T1 lesions here. And depending on which organ you're looking at, the esophagus, stomach, and colon, all a bit different, you can then target different levels of submucosal invasion. Once you have a T2 lesion, of course, then a patient requires surgery for adequate lymph node assessment. So what are the main indications for endoscopic submucosal dissection? Well, if we take a look at superficial, very large polyps of the gastrointestinal tract, sometimes it's very difficult to remove all in one piece. And so, in areas, for example, in the esophagus and stomach, there are some good reasons to think about endoscopic submucosal dissection. And I'll get into that a little bit further. Early squamous cell carcinoma of the esophagus, squamous cell carcinoma of the esophagus is associated with a higher risk of lymph node metastases compared to adenocarcinoma of the esophagus. And so early squamous cell carcinoma, this is probably the best way to deal with it. And large colonic adenomas, subepithelial lesions of the GI tract that we see, and also an access to the submucosal space for other therapeutic procedures, which I'll get into. So this is how we usually do it in the colon, and that is if we see a very large polyp in the colon, we inject a little bit of submucosal injectate, raise the lesion, and if it, practically speaking, if the lesion itself is too big for the snare, then we end up removing it what we call piecemeal or in multiple different pieces. And this is actually very safe, very efficient, and actually for very superficial lesions, really the way that it should be done. And you can see here that in the end, we've got a nice margin of normal tissue around this piecemeal resection. Okay. However, there are some problems with EMR or endoscopic mucosal resection when the lesion gets very large or if it's in a difficult anatomical place. So, for example, in this study from Australia, they looked at almost 500 patients, and they had a complete resection about 89% and had some complications of about 8%, mostly due to either a bleeding or perforation. But the recurrence rate is just over 20%, right? And subsequent studies have repeated these results, and it's settled out to about 15 to 16% a recurrence risk after a piecemeal resection of large colonic polyps. Here's another study, also, I believe from Australia too. Like once again, just outlines the fact that the larger the polyp that you have, the less capacity you can fit the entire snare around the polyp, and therefore piecemeal resection can lead to a residual adenoma. As mentioned before, it's colonic EMR or polypectomy is an easy procedure with a short procedure duration. It's very fast to do, and it's successful and safe in the majority of the cases. But the problems with colonic EMR, once again, is in large lesions, lesions that have difficult access, those that have been removed have a subepithelial fibrosis that's often very difficult to deal with. And as Dr. Enns has always said, not to remove these polyps if you don't think you can remove it all in one piece. And of course, there's sometimes injudicious use of a tattoo around the area of the polyp sometimes cause submucosal inflammation and therefore makes it more difficult to remove. A fragmented specimen is typical for a piecemeal resection, and once again, there's high recurrence rates for this. So the advantages of ESD is that when we do this procedure, it's an en-bloc endoscopic resection. There's a lower recurrence rate and a higher R0 resection rate or curative rate. And it's certainly an option where EMR is not feasible. Because the specimen is removed in one piece, you get a good lateral pathological assessment, but you also get a good deep margin assessment as well by pathology. And where the advantages of ESD really come out is the location of where your superficial neoplastic lesion is. So in the colon, for example, if you have a large polyp in the colon, it's fairly straightforward to then send the patient on for surgery, which now is laparoscopic. It's very easy. It's very safe, right? But the stakes get higher the higher you go. So, for example, if you take a look at the stomach, you have a superficial neoplastic lesion, early lesion. Patient then goes for gastrectomy. And depending on where this tumor is, patient can also end up with a total gastrectomy. And I don't need to now tell you about the esophagus. If there's a superficial neoplastic lesion in the esophagus, the morbidity and mortality of esophagectomy. So if we take a look at the data of ESD compared to EMR at the differing levels of the resection, we see here that on the right of this odds ratio of 1, it favors the ESD group, ESD resection both in colorectal, esophageal, and gastric superficial neoplastic lesions. Okay. Now the other thing to make note of is that most of these studies come from Japan, right? And that is because this technique has been pioneered in Japan, mostly due to the higher prevalence or incidence of gastric cancer that they have there relative to North America. So disadvantages. There are disadvantages to ESD. Number one, there's a higher complication rate associated with this, and understandably, perforation is one of them, but also bleeding. Because you're meticulously dissecting away the submucosa, it is a longer procedure time. And getting adequate training is also difficult in the West. And that is mainly due to what I mentioned about the incidence of gastric cancer, early gastric cancer, where superficial lesions removed from the stomach are a lot safer from a practical standpoint. And when practitioners are starting to learn this technique, usually the stomach and the rectum are the safest place to start learning. And also the choice of instruments that are available here in North America are not the same in Asia. And so if we take a look at the perforation risk in the Japanese experience, looking at over 2,000 ESDs, they found that about 5% of patients would have developed a perforation. But it's interesting to know that some of the earlier perforations between 1987 and 1993, when there was no access to endoscopic clips and closure devices, that they all went, that 4 of them went for surgical treatment. Of the ones that went for endoscopic closure, we see that a large majority of them actually have successful closure with endoscopic clips. Okay, so just to give you a sense as to what the ESD looks like, and this is a lesion that was seen in the antrum of the stomach. Okay, and it was a patient that had recurrent overt bleeding from this hyperplastic polyp. And so the decision was made to resect this lesion. Now, surgically, it would be a distal gastrectomy, but we decided to go with the endoscopic approach. And we see here, we look around the polyp itself. And then the next thing is we put singe marks around the lesion itself to define the lesion pathologically. Eventually, we will cut around on the outside of these burn marks just to ensure that the pathologist has said that we've gotten the entire specimen. So the next step is to inject the submucosal injectate, which is hydroxyethyl starch with a little bit of methylene blue, and then using essentially a short needle knife, gain access to the mucosa. And there's a lot of blood vessels in the superficial submucosa, so hemostasis is key. And so once we gain access into the submucosal space, you see the blue is actually the submucosal fat that's been colored by the methylene blue. And if you look a little bit further and down, you'll see a little white, a vague white area there. That's the muscularis of the stomach. And we'll see in the next clip, you'll appreciate the muscle layer a little bit better. Is that white part underneath? So we do have endoscopic landmarks as the dissection goes along. Now, of course, once again, there's. Oh, okay, that killed the video. Yeah. Let's see if this. Put this back up and see if it works again. Okay, so when we encounter a submucosal blood vessels, we prophylactically cauterize them. Not working. Anyways, okay, and it crashed again. All right. Okay, so essentially, the rest of the video is looks like it's back. Okay, it's back. Yeah. So then the last part is to incise the entire specimen. You can see here, this is all muscle layer of the antrum. That specimen is typically removed and then pinned on a cork board and sent to pathology. Okay, so I'll just move on before it crashes again. Okay, so the other thing about ESD is that it's an access into the submucosal space, and we use that to tunnel into areas between the mucosa and the muscularis. And this type of approach has been investigated in the treatment of achalasia, which, as you recall, is a tight lower esophageal sphincter pressure due to muscular spasm. And this has been used to develop a technique called the per-oral endoscopic myotomy, or a POEM, right? And essentially what that is crashing again. Okay, this is the last picture.
I can get back to you.
Sure.
Yeah, it should be.
Okay. Anyways, okay. It's unfortunate, but I'll describe it. So for example, in the esophagus, you have a dilated aperistaltic esophagus, which is typical for achalasia. And the difficulties in achalasia is really dysphagia due to spasm of the lower esophageal sphincter. Now, how it's done surgically is usually a laparoscopic approach would incise the muscle on the adventitious side, right, without disrupting the mucosa. But this per-oral endoscopic myotomy, or POEM, is accessed through the mucosal side and doing the myotomy within the space between the mucosa and the muscularis. Okay, and so the question is, how does that not cause mediastinitis and sepsis? Well, the thing is that after the myotomy is performed, the opening, or the mucosotomy, is then closed with endoscopic clips, right? And with antibiotics, patients actually do very well with that. So this technique has been around since 2008, once again in Japan. And the 5-year data shows that it's equivalent in terms of efficacy to a Heller myotomy, right? Longer-term data is still pending from that, okay? The GERD rates post-procedure is also similar to that of surgery. Okay? I hope yours works. No, it's just like trap hair. Okay.
Yeah, they're working on it.
Working on it, okay. Sorry, my video crashed.
Okay, so we're next going to talk a little bit about diets. It'd be nice to show you something, but can I try again, or are they still working? So we're going to talk a little bit about diets. I might as well talk. So I'm going to talk about some popular dietary things. I don't think you need a slide for me to talk about that. So we're going to talk today really about FODMAPs, mostly. As those in the audience who've heard about FODMAPs can put up their hands. FODMAPs, okay. thanks to Australians. Where are the Australians in the crowd? So this is, Australia's brought quite a few things to gastroenterology. They won the Nobel Prize for Helicobacter pylori digestion. And FODMAPS was a diet that was produced, discovered and described at Monash University in Brisbane. That's in Brisbane, right? Melbourne. In Melbourne, Australia. So Monash is a well-known university in Melbourne. What is the one in Brisbane called? Starts with an M as well. Anyway, so they initially discovered this or described this diet in 2005, and the original idea, and I read through the paper, which didn't make a whole lot of sense to me. The original idea was that FODMAPs might produce molecules in the terminal ileum and colon, which lead to disruptions in the epithelial barrier, which then could lead to Crohn's disease. So the original study was a hypothesis related to Crohn's disease. Obviously, that didn't seem to get very far because that got waylaid, and I never heard any more. I haven't seen much more about Crohn's disease since the 2005 hypothesis paper. But in 2008, the same group described the use of this in an irritable bowel syndrome.
I'll work on it. You go ahead.
Okay.
Yeah.
I need to see my slides.
Oh, yeah.
Where's my slides?
Yes, I'll pull that out.
I can put it on here. So there are some other diets we're not going to talk about today. So the diets are all the rage in the diets are gluten-restricted diets. You've heard about wheat belly. There was just a paper published this past month in Gastroenterology suggesting the problem with that was actually not related to gluten, but was related to fructans, which are part of the FODMAPs diet. There's some other specialty diets we're not going to talk about today: the paleo diet, the Mediterranean diet, the DASH diet, and we're going to just only focus on the FODMAPs diet.
Okay, unfortunately, I'm going to have to, this is, for me to do this, I'm going to have to keep changing this, so.
Let me get my computer.
Yeah.
It's on my computer.
It's up to you what you want to do.
Yeah. So FODMAPs stands for fermentable, so FODMAP, so fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. So polyols, do you know what polyols are?
If you don't have any videos, I could actually put it on this one too.
Oh yeah, put it on that one.
Yeah.
Put it on that one.
I just want to release this. I'm not sure where to go here. I don't want to pull this out.
Oh, it should be.
It's just so busy here, I can't see it. Likely it won't be a problem, but
it should be. Where's your?
You want to check?
It's usually down on the bottom here.
It should be up there.
You want to check?
Oh,
Yeah.
I just want to release this.
They want to inject. Where's
I
the
don't
thing?
want to pull it without releasing
Oh,
it.
there it is. Okay,
Thanks.
that's fine. Okay, good. You can do it now.
Okay, thanks.
So fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. Polyols are the things that you have in our chewing gum, our sugar-free chewing gum: sorbitol, mannitol, xylitol, and maltitol. I actually haven't heard of maltitol, but the other ones are well known. Yeah.
I want to slide. International medical.
There you go.
Okay.
Okay, great.
So we're going to look at what constitutes FODMAPs. I already talked a little bit. We're going to look at the data for IBS and the difficulties with that. And I already told you what they are: fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. And most of these things are really fructose-based. So I mentioned it was coined in 2005 from Monash, which is in Melbourne, which I had my slide. I would have told you it was Melbourne, but that was and so you pretty much, the monosaccharide is pretty much fructose. This one over here is pretty much fructose. The disaccharides can be things like lactose, which of course doesn't contain fructose. And then there's fructans. Fructans are fructose polymers, and they fall into two major categories: FOS, which is fructooligosaccharides, and inulin, which is a larger group of fructose polymers. And there's galactans. And galactans are famous because they're present in things like beans. You know, Beans, the musical, yeah, the number one. And they contain a couple of galactans called stachyose and raffinose, but we're not going to talk about those much today. We're going to talk mostly about fructose. And so if you look at this gamish of things that are available on a low FODMAPs and a regular and a diet containing FODMAPs. So you look at all this and you can see it's an incredibly complicated slide. So I hand these out because I can't be bothered talking, and we're gastroenterologists. We don't have 15 minutes to talk about diets. So we hand out that low FODMAPs diet, and these are the foods that contain FODMAPs, and these are a million different kinds of foods. And so one of the concerns we're going to see about the diet is related to the fact that this is a complicated diet. It's not immediately obvious. Everybody can pretty much guess that where lactose is from, it's from dairy products, but these are from a million different sorts. And in general, the only sort of source of gluten you can get from FODMAPs, from a low FODMAPs diet, the only source of gluten you can get is spelt bread. You ever know what spelt is? Spelt is an ancient wheat, but otherwise you can't get most of the others. So it's a very complicated diet, and when they did the studies, they said they could teach the diet in 10 minutes. I don't know how they did that. Obviously, Australians, at least from Melbourne, are much smarter. We know that some of the other Australians aren't so smart, but the ones from Melbourne are obviously very smart. I got to work with a bunch of Australians after this, so I think I'll just go home for the rest of the day. There's actually, if you go on your app store, or if those of you who are unfortunate enough to have Android products, can go on the Android store, or whatever it's called. But you can actually get a FODMAPs diet, and there's a million FODMAPs diets. This is the one produced by Monash University. I paid $10.99 for it, and I was supposed to get reimbursed from Dr. Enns, but that never happened. But you can actually go to the store. In addition to having sort of what FODMAPs is, you can actually use it to go to the grocery store, and you can look up some product. You want to get such and such a thing, and you push the button, and it says, oh, you can't have it because it's got FODMAPs in it. So there are a couple of studies. The studies are hard to do, and diet studies are hard to do. So one of the original studies was only about 4 years old. It was published in Gastroenterology. They took 30 IBS patients and 8 controls and randomized them to really 3 weeks of a low FODMAPs diet and 3 weeks of a typical Australian diet, which I think consists of kangaroo and crocodile and emu, as far as I know when I was there. And there's a 21-day washout period and crossover, and they actually provided all the food for free. They cooked the food in a commercial kitchen. And they had this visual analog scale, which was kind of a weird thing where they how much problem they were having, and it was from really a 10-centimeter long scale. And they would draw it across, and they would consider 10 millimeter difference considered significant. There wasn't really any basis for that, as far as I can tell. And you can see from the data that the patients on a low FODMAPs diet did better than those on a high FODMAPs diet. I didn't show you the control group. The control group didn't make a difference whether they had numbers that were lower than these. It didn't make a difference whether they're on a typical Aussie diet or whether they're on a low FODMAPs diet, suggesting that at least that they had fewer IBS symptoms in patients on the FODMAPs diet. But Camilleri, who's based out of the Mayo in Rochester, and Acosta had some complaints about obviously part of the problem is it's unblinded. The two diets don't look the same. They commented that this visual analog scale was not validated. There were a lot of follow patients who had to have last observation carried forward because they weren't captured. There was some psyllium and resistant starch in the FODMAPs diet, and they just said we can't agree that this study has provided high quality evidence of efficacy in the low FODMAPs diet in patients with IBS. There's a much more recent study, and there aren't a lot of studies when there's a lot of interest in this whole area. But there's a recent study published last fall, I think it was, in Gastroenterology. This was a study out of the UK with some contributions from the Aussie group. And it was interesting because in the early days, when you're looking at the use of FOS, which is fructose oligosaccharides, and inulin, those things were actually added to polymeric diets. So you would have an osmolite or one of the other things, and they used to add FOS and inulin to those because FOS and inulin are prebiotics. Prebiotics are those things which will promote the probiotics in the bowel, much cheaper than actually giving probiotics. So you actually feed them things which allow these different species, particularly Bifidobacter, which is a probiotic, it allows it to multiply. And one of the concerns about taking FOS and inulin out of your diet is it's been shown that you actually reduce Bifidobacter, which is a probiotic. So there's some concerns about this. So they, in this study, they did a low FODMAPs diet, and they added a probiotic, which is really the equivalent of BSL-3, which contains some Bifidobacter. And they analyzed both how the patients did, and again, they had a weird thing called adequate symptom relief. Either with adequate or not adequate, it was sort of a binary thing. And they looked at the stool Bifidobacter species, and they had 4 groups. They had a sham diet, a FODMAPS diet, and then with or without a probiotic. And cut to the chase is that it didn't quite reach statistical significance. Very close. The more of the patients on the low FODMAPS diet compared to the sham diet had improvement. Didn't quite reach 0.05, was 0.051. And the question was, did you have adequate relief of your symptoms over the last fast 7 days? So what was interesting about the study is they looked at the Bifidobacter species, and if you added the probiotic to the species, you would improve your Bifidobacter concentrations, relative abundance in the stool. And so it is a way to get around the major complaint, which is that although FODMAPs may increase the amount of gas you're producing, may cause more bloating, discomfort, in fact, they also decrease the Bifidobacter species. And so they were adding Bifidobacter back to the diet. So the studies show marginal benefit for FODMAPs. I know that Dr. Telford, who's looking at her phone right now, has found the diet to be very helpful. Okay, Jen. Yeah, she likes it a lot. But the data are not overwhelming in terms of its benefit, and the methodologies used for proving that it's beneficial have been questioned. It's a complicated diet. There's pros and cons. I think the basic pro for complicated diet is that when you send the patient off for the diet and they come back and they say they're not any better, it's pretty easy on this diet to say they haven't followed it very closely enough because it's so complicated that nobody can follow it very closely. It does preferably involve a dietitian because we know as gastroenterologists we're not the best at going over diets and it would be tedious. So you really should have a dietitian, and there is a dietitian that's interested in pursuing this in the city. We know that it adversely affects Bifidobacter in the stool, which we think is an important bacterium in the stool. Because of that, it's meant to be temporary. Having said it's meant to be temporary, when you looked at some of the studies that the Australians did, they had people on this diet for a couple of years, but it does decrease Bifidobacter species. It does decrease the biodiversity in the stool, and so it really meant to be a temporary diet. And because of that change in the fecal microbiome, there's concern about the safety of this. And it's generally recommended only for 4 to 8 weeks, and then you introduce foods. There's not, as far as I can see, great guidance about how you introduce the foods, but you have to start somewhere, so you introduce some of the foods, see what they do, and usually wait a week or two. But the idea is that they don't stay out indefinitely. And that's food. So we'll take questions now for Dr. Lam, and I will take questions now about short bowel syndrome I think that although the drug for short bowel syndrome is very expensive, I think it's exciting times because, like everything else, there will be a drug that will come down in price, and it may be worthwhile. When it comes down by a factor of 10, it really will be something that we could use, I think, for some of our patients to at least reduce their needs of fluids and possibly get some of them off TPN. And the FODMAP side is something that I think everybody in our office uses. And I look forward to working with one of the dietitians who has some interest in this particular area. But we'll take questions.
First of all, I assume that GLP-1s are diabetes drugs that cost more money that have been tried and didn't work.
The GLP-1s? No, they're still looking at GLP-1 drugs. So, yeah, but they're still interested in those, but there hasn't been, mainly the person that's been driving this is Jeppesen in Denmark, but there are several other, I've been asked to look at a couple of more polypeptides for different types of things. We know that human growth hormone doesn't work, but there is some interest in GLP-1. Haven't really got great data on yet, but there's also other kind of peptides that are going out there. So I think that it's at least opened the door for exploration, because in the past we would use antidiarrheal drugs like codeine or loperamide or diphenoxylate and other narcotics. Sometimes we would try anything else that we could try to slow the bowel down. And I haven't talked about the pediatric group. There's surgical procedures like step procedures. There's all sorts of things to try to get more bowel out of these people, because it really is a pretty miserable life to have 2 or 3 liters of output through a jejunostomy and have to infuse, 3 liters that you're losing plus another 2 liters, so 5 liters a day. You're pretty much tied down to an IV most of the time. So even in a reduction, if we can get the cost down, even if you reduce for some people, get them off 1 or 2 nights a week, if the cost was reasonable at $300,000 a year, that seems a little outrageous at the present time. But I think that it's opened the door for all sorts of other peptides that people are now going to be looking at. So I think that the importance, this drug is available and some companies will pay for it. But I think what it's done is open up a whole new interest in using polypeptides for this condition.
Seeing a hypothesis that patients who do not have celiac disease, think they get better on a gluten-free diet are actually getting better because they're following a FODMAPS. Is that still?
Yeah, in fact, the paper just came out. It was just published in this month's. I was going to present the paper, but I thought time was going to be short. It was already too long. But there was a paper just came out this month in Gastroenterology that suggested this so-called non-celiac gluten sensitivity problem. They had a randomized trial where they looked at a high fructan bar compared to a high gluten bar, and the people actually didn't do very well in the high gluten bar, but did well. The people that had so-called non-celiac gluten sensitivity actually improved on a low fructan. So they did better. They did worse when they got fructan than they did when they got gluten. So there is some suggestion that those patients that have so-called non-celiac gluten sensitivity may in fact have a FODMAP issue going on. So yeah, you're right, and that was just published this past month, although it was available online a couple months ago.
So I've had patients to me in recently in this diet that I'm hearing about is a low lectin diet, so avoiding all the nightshades, vegetables, and wheat as well. And there's some people will talk about we were actually sensitive to gluten, we were sensitive to the wheat germ, which is high lectins. And do you know anything about that?
No, I don't know if there. Andre, do you know anything about the lectin? No, I'm not. Yeah, leaky gut's a favorite one, but I'm not familiar with that particular diet. There's a new diet every other week, but the FODMAPs has probably got the most role, and the gluten-restricted diet. But it was interesting to see that study in gastroenterology suggesting it was actually the fructans are more important than the glutens.
There was some studies in gastro with using the COA that was considered an inflammatory diet with the high lectins and looking at you're predisposed to inflammatory types of colon cancer, and there's actually been quite a bit of basic science research.
Okay, good. You can give the lectin talk next time.
Dr. Whittaker, we didn't have these disorders 30 years ago, or at least their epidemiology has dramatically changed. We had a lot of irritable bowel and stuff like that, but these disorders with eating didn't seem to exist 30 years ago. They certainly didn't exist in certain genders. There's much different gender predilection, whereas now there are clear changes between, what was 30 years ago and now. Your postulates on why this has changed, because I think there's no doubt the epidemiology has changed, and we just didn't really see these types of disorders 30 years ago that we're seeing treated now. You described IBS, but I think we see a lot of other GI type disorders, which may be more difficult to even describe.
Yeah. I've seen no epidemiologic hypothesis about this. I don't know if anybody else has, but I've never seen an epidemiologic hypothesis. I mean, I think that I think we're in a very privileged position in this particular country and in this particular city. And I think these people clearly had IBS. IBS has been a fairly prevalent condition for many decades. And I think that the dietary part's been looked at. And I think people are exposed. I mean, if I had a hypothesis, I think they're just exposed to so many more things on the internet that they read a lot, and I'm not sure how much there really is different as opposed to real differences. We know, for example, there's been some interesting data on gluten. When I was training in Toronto in the 1920s, it was said that the highest prevalence of celiac disease was in Western Australia, and the prevalence in Western Ireland, sorry, I got Australia in the mind today. But anyway, the prevalence in Western Ireland was said to be 1 in 300, and yet we know that the prevalence in the US and Canada is felt to be somewhere between 0.5 and 1%. And if you look at serologic data, I mean, looking at TTG antibody titers, there's been a clear increase in TTG antibody titers, and there's any number of theories as to why that might be. But there clearly are some trends that you can document where you have some good data. I think for the other things, I don't know. The internet may play a huge role. I'm not sure about the other data. Somebody's got to ask us a question on ESD. This is really fascinating stuff. So those of you who, we have had to send patients to Japan who have these things that Eric could now take out. And I think those are pretty exciting. I'm really excited that one of the members of our group has taken this on. It's a very arduous, difficult thing to do, which requires an incredible level of expertise. And I'm very happy that Eric's decided to take this on as part of our group.
So, Eric, so do you think the Russians then are basically controlling the dietary?
I think it's all about the Russians and and the Syrians. Yeah.
Eric, the poem for achalasia. We're not doing that, are we? In Vancouver.
Well, actually, some thoracic surgeons have started doing it in Surrey, right? And so I'm not sure exactly how many they've done.
Like if we were to have an algorithm as to how to manage achalasia, my understanding is that the gold standard is a hyalomyotomy, and if you're not surgical candidate, then you consider botulism, injection, or other things.
That is correct, yeah.
Should we replace that with
that's when as POEM gets more developed, right? I mean, there's lots of good data about it right now, and I think that's a reasonable option instead of hyalomyotomy. Right?
And how, just a quick question, how does it differ than when we used to see the needle knife to treat the Zenker's diverticulum that we used to cut that bar? What's the difference between that and
right? Yeah, so the Zenker's diverticulotomy is just a direct incision of the cricopharyngeal bar, right? With POEM, what you're doing is you're actually tunneling down the space between the mucosa and the muscularis, and it's the length of the dissection down that actually protects you from mediastinitis and from infection, right? So that long tunneling. Once it's closed, it just collapses, right, and then maintains sterility there with antibiotics.
So the difference between an internist and a gastroenterologist is I could tell you a poem about achalasia.
Go for it.
There was a young woman from Nantucket.
No. Next week's rounds is advertised on the assessment forms. As you've probably seen, it's nephrology, a bloody dilemma. Thanks to both of you.
I don't know that poem before.
I'm still not sure. What does it cause?
Well, because the idea is that the fructose is in the I mean, that's the theory, but I mean,
So many on
Yeah, I think the dietitians are better, but if there's a dietitian named Anne-Marie who worked with us before, and Marie's actually done a clinic of dietitian. I mean, but so she's doing it. I don't know whether the dietitian might possibly to the head of the dietitian, Francis. I speak to Francis this week. I can talk to Francis to see if they have someone who's going to focus on the FODMAPs. It is a very specialized diet that requires a lot of work. Now, there's a lot of information, but it'd be helpful to have a dietitian who spend the time.
But I'd like to you see her, see if even a dietitian will be appropriate.
Yeah, okay. So your name is Stone?
Yes,
Where's
10.
I may have time to see her this week. I'm going to call for But they're wrong. Yeah, that's her. Ashley Stone.
Okay.
Okay, Ashley Stone. I'll put it in.
I missed the drug portion. I was watching it tonight, so I saw the rest of it.
The track our slides in where is it?
I actually have terrible IBS. When I eat convenient food, like right now, I'm going to be doubled over in about 20 minutes.
Are you?
But it's so true. Like, I got my colonoscopy. I know it's not cancer. And sometimes I just accept I'm going to get IBS later tonight because I feel like pizza. But because I'm a gastroenterologist, I'm not pontificating over it. I'm not getting depressed over it. I'm not crying over it.
We have one of my friends in Toronto.
But truly, I say this to patients. No, you don't have to be on this diet. Just live with the symptoms. Like, I'm not trying to be mean. But because I have it,
And my friend
I
Wallman.
feel validated and saying, well, you can just live with cramping. I've already scoped you. It's not cancer. You know?
Yeah, so so Steve Wallman had
Your call will be disconnected.